Hi, my name is Dr. Cathy Eng from Vanderbilt-Ingram Cancer Center, and I'm here to give you state of the science updates regarding treatment and research. And thank you for inviting me to speak at your summit. These are my disclosures. This is the estimated number of new cases from 2020 up until 2040. And as you can see here with anal carcinoma, despite improvements with HPV vaccination, we are still expecting a high increase overall for cases globally. We also know that within the United States, the incidence continues to rise by 2.7% per year. And those that have distant metastatic disease, which will be our focus today, the estimated 5-year survival is approximately 36.2%. What does that mean? It means that 50% of patients, though, will still exceed 36.2%. And I want people to not get inundated with that number. And those numbers relative to other malignancies actually is very favorable. In regards to the current standard of care, we know that there was 2 systemic chemotherapy regimens available to patients, as well as in second-line therapy. We have now seen that there's a role for immunotherapy. And once again, I highly encourage individuals to always consider participation in a clinical trial whenever possible. So what have been the recent developments? Well, we now know that ideally carboplatin plus paclitaxel is preferred versus 5-FU and cisplatin just because of reduced toxicities, but equivalent response rate in the high 50s, almost 60%. And we also know that immune checkpoint inhibition as a single agent is approved in the refractory setting or in the setting in patients that have had at least 1 prior line of therapy. There's obviously new approaches that are currently being investigated. And I have a short period of time to try to go over those with you. Once again, systemic chemotherapy will give you response rate, as mentioned earlier, about closer to 60%, and the progression-free survival or time to tumor growth is roughly about 8 months. That's the median, and there was a demonstration of improved overall survival. Immune checkpoint inhibition as a single agent does result in response rate of anywhere between 10 and 24%, and the progression-free survival or time to tumor growth is approximately 4 months. A lot of people want to pursue immunotherapy up front because they think that is the best option, but I kindly would like to remind patients that the response rate for immunotherapy as a single agent is not as favorable as chemotherapy for newly diagnosed patients. There's additional interest in looking at molecular alterations, very similar to other GI cancers. However, this has not been well assessed in metastatic squamous cell carcinoma of the anal canal. And once again, this lecture is largely for the squamous cell patient population. Personally, in my own practice, I always check next generation sequencing to see if there's anything that's potentially targetable, but it is not necessarily approved as a standard of care. And so you should check to see if your doctor does cover it, your insurance covers it, just to be on the safe side. This is off the NIH website, really just demonstrating the importance of immune checkpoint inhibition or PD-L1 therapy, which really focuses on T-cell killing, which are basically your own immune system being able to engage and kill the tumor cells, with also the consideration of ipilimumab, which I'll show you a trial that we've recently completed, which basically works on T-cell activation. These are the currently approved agents in the treatment of anal carcinoma. We just recently presented our data at the GI ESMO meeting in June of this year, looking at whether or not single agent versus double agent immunotherapy would be beneficial in patients with previously treated squamous cell carcinoma of the anal canal. And this was the study design. The primary endpoint was progression-free survival. It's a 1-to-1 randomization of Nivo plus or minus ipilimumab, which is a CTLA-4 inhibitor. And Nivo-Ipi is a common combination that has been assessed in other malignancies. And we have had this study open for quite a while. It just took a while to get completed, unfortunately, because several patients were receiving nivolumab off protocol. And also because of COVID, there were delays. So these are the results. We enrolled a little less than 100 patients. Actually, let me take that back. We enrolled 100 patients. And as you can see here, the progression-free survival is slightly better for the combination, but was not statistically significant. And in regards to response rate, although the combination was slightly better, it was still not statistically significant. There were some complete responses in both arms, and I am aware that there were some patients that still have had a complete response for long term. Once again, unfortunately, due to COVID, some patients were lost to follow-up, and they decided to receive treatment off-label because it was hard for them to travel back and forth. This is the spider plot looking at 6-month progression-free survival, and although slightly in favor, once again, for the combination, it was not statistically significant. And this is the overall survival results, but not statistically significant. And overall survival is dependent upon subsequent lines of therapy. One thing is noticed, there were less toxicities in the single agent arm, and I think that's very important. So if the study has demonstrated non-statistical significance for progression-free survival and overall survival, and is less toxic for the single agent arm, I would therefore recommend that single agent therapy remain the standard of care, because there's no statistical benefit for the combination, which puts you at risk for increased toxicities. So what other trials are pending? Well, retifanlimab is being evaluated largely in the EU, as well as the UK, and there's a couple of sites in the United States. It's a 1-to-1 randomization of carboplatin plus paclitaxel for newly diagnosed patients, plus or minus retifanlimab in a 1-to-1 randomization. The primary endpoint is progression-free survival. They intend to enroll 300 patients. We here in the United States have nearly finished enrollment. It's about 140 plus patients for our trial, which I am the lead investigator on, in a 2-to-1 randomization. So twice as likely to be randomized in the investigational arm, plus or minus nivolumab based upon our earlier work. We're also collecting HPV circulating tumor DNA with the support of the Farrah Fawcett Foundation, providing us a small grant, as well as Sysmex, who is running the analysis for us. So I would like to thank them for their cooperation and collaboration. And then ECOG, of course, is sponsoring our study. So this trial is almost nearly complete for enrollment. Once again, 140 plus patients out of 205 expected. There's a lot of interest in adoptive T-cell therapy. This is actually some early data from our SQUEEZE trial, which was for all HPV-associated malignancies, which is a bioengineered E6/E7 HPV-16 vaccine. Our trial is currently temporarily on hold. As you can see here, there was some correlation with CD8 cells, which appears to be suggestive of being able to engage and increasing T-cell infiltration into the tumor. And we hope that this study will reopen. There is the study that was reported at ESMO 2020 from the NIH. However, I could not find any additional data regarding this. I hope that we'll see some published data. There's also another trial that's being conducted by Dr. Hinrichs at Rutgers, which is looking at, once again, an HPV umbrella trial for HPV-associated malignancies. And they have seen some data in patients that have previously been exposed to immunotherapy. Once again, it's not specific to anal carcinoma, but it may be promising. It is a bioengineered vaccine approach as well. We are also one of 6 sites participating in this study supported by Sumitomo of TP1454, which basically is to reduce and deplete glycolytic metabolites associated with cancer cell growth. This is based upon very promising data from one phase 1 study that was completed, and they noticed some very promising activity in anal carcinoma. This is an expanded cohort study, specifically in metastatic refractory anal cancer, and allows up to 3 prior lines of therapy, and this trial is ongoing. So what are the gaps in knowledge? Once again, we still don't have a defined treatment approach for those that have had progressive disease following immune checkpoint inhibition or immunotherapy. Clinical trial enrollment is critical. I hate to continue to see patients being treated in the community that have received multiple lines of therapy without a lot of data. and they could have been a candidate for a clinical trial. And that's really the only way we move forward the needle with advances in treatment options. And once again, we still need to encourage pharmaceutical companies to become engaged with this rare cancer, keeping in mind an advancement in this HPV malignancy may help other HPV-associated malignancies. I would like to acknowledge my lovely friend, Michelle Longabow, who passed away, not due to her malignancy, but due to complications. Otherwise, she was an amazing nurse, author, blogger, friend, and national patient advocate for the NCI. And we'll always miss her dearly. And I always appreciated her voice in acknowledging this rare cancer. And she was an amazing metastatic anal cancer survivor for approximately 8 to 9 years before she passed away. Unfortunately, once again, not from her cancer, but due to other complications. And thank you so much for your time and attention. And I hope you all are enjoying this meeting. Thank you.